Good morning. I do hope that we're live and I do hope you're on the other side. Good morning and welcome. For those of you who don't know who I am, my name is Brennan and I'm the Executive Director of the Health Consumers Council. And I'm here with the Director General of the Health Department, Dr. David Russell-Weisz. And just before I begin, I just want to start, as the Health Consumer starts everything that we do, I want to provide an acknowledgement to country. So wherever you are across our vast state, I would like to pay respects to the Aboriginal peoples, the traditional owners of our land, to pay respects to elders past, present and emerging. It is so very important that we always recognise the disparities in health outcomes between Aboriginal and non-Aboriginal Australians. So welcome everybody to the very first inaugural, indeed, fireside chat. So this, as an inaugural event, what you may find is that from time to time there may be a few technical glitches, and I know that all of you online have been so forgiving as we have found our way to pivot to online engagement. And so again today, I hope you will bear with us if there are any technical glitches. So we have this incredibly busy man here for just 1 hour. What we have done, as you know, is through the registration process, we asked you to ask questions. Now, I did do a little bit of synthesising of the questions and theming of the questions, and even so, we have quite a lot, it must be said, and it's unlikely we'll get through absolutely every single one. Some of them we may be able to provide a response after, but others have inspired the topic of the next fireside chat, because we are aiming to run these fortnightly. So without further ado, I don't want to take up any more airtime. I just wanted to start. I wanted to ask, how has it been? This is literally the first time I've seen you in a long time. Normally I see you fairly regularly. Yeah. So I guess I'd just like to, I know all of the listeners will be interested to know, how have you found managing this unprecedented situation of the COVID-19 pandemic?
Thanks, Pip, and look, it's great to be here, and I'm glad it's a fireside chat because it's hopefully it is more conversational. And I'd like to also join Pip in acknowledging the traditional owners of the land that we're meeting on today, and I know you're from all around this amazing state that we all live in, and would like to acknowledge the traditional owners and pass my respects on to their elders past, present and emerging. It's a great question, but I do get asked it quite a bit. How's it been? And I usually start, well, it's better than it was 3 or 4 weeks ago. Yeah. I get accused by my wife and my children of talking more to Andy Robertson, the Chief Health Officer, than talking to them. And I think that's probably true. I think from a personal perspective, and having worked, some of you who I'm talking to will know that I've worked at Fiona Stanley and also Perth Children's Hospital, and overseen some extraordinarily complex projects working with an incredible team. There's no real difference here. I have an incredible team. Things have changed, and I think Pip's point about me not seeing her, business as usual has had to change. Business as usual has had to change because we are more in a command and controlled structure than we were before. And therefore I'm not probably doing some of the things that I normally would do. It has been, I would describe it as relentless, and it's been relentless for some very senior members of the team. It's been relentless for, say, our contact tracing team, our extraordinary public health arm, and we built a clinical services arm as well. But I'll be really candid, and I hope you will want me to be candid. We can plan for as many disasters or incidents, and we have planned, I think, as a system for an maybe not an earthquake, but maybe, where we get bushfires, where we have in the health system major ICT failures, where we might have an influx of measles, all things like that. But if somebody said, have you planned for a pandemic that actually might last, and I'm not saying the pandemic will last, but you might have to have a response that lasts for 12 to 18 months, I'm not sure that any plan had that written down. So we've had to be very adaptive. And I would say, just to, so I could talk about the question the whole time, but to end that point is, how has it been? It's been, I'd say, incredibly hard, but incredibly rewarding, because we've had an extraordinary team. And what we're trying to do at the moment is, because we're in for the long haul, We are trying to learn from the decisions we've made and maybe, as I always say, mistakes we've made along this way. But I would say I would rather be in WA, I'd rather be in Australia than anywhere else in the world, bar New Zealand. I think we are all in a very privileged position, but we must not be complacent. We really must not be complacent. Pip's going to ask me what worries me, and what worries me is complacency. People are saying to me even, oh, the virus is beaten. No, it's not. It's here, it's alive and well. We have to be vigilant. We have to have a great public health response. Our hospitals have to be ready, and I'm sure we'll talk about that during the hour we've got. We have to be ready to give the best care we can to patients right across the state, and that can be ready from giving care for COVID or our business as usual, non-COVID. And I don't want to go back to business as usual because some of the reform that's come through the Sustainable Health Review, we've made inroads that we would never have made if it was business as usual. So I'll stop there.
Yes, thank you for that. And in some ways, a lovely segue to my next question, I wanted to, the question that came up a lot, and this is through the survey work we've been doing as well, is around consumer engagement. So yes, one of the things that we've noticed is that the system has had to defer consumer engagement when people couldn't engage in person. And so we're just interested to know what are the lessons that the department and health service providers will take away, because what we're hoping is that we will be part of your dream team, should anything like this, God forbid, ever happen again, that consumers will be embedded in that dream team.
Well, I'm actually not planning for whether it should have happened again. Anything we can learn about engaging consumers more in our dream team now has to be for now, because we are not in this. This is not ending in 2 weeks' time. We are not disbanding SHIC, which is our State Health Incident Coordination Centre. We are still in a state of emergency under the Emergency Management Act. We are still in a public health state of emergency. We are still in this. We are all in this together. One of the things I will take from here is how we do embed you better when we've not got a lull, but certainly the acuteness, it's not quite there.
Yes.
I would actually say things have changed a bit here, not just for consumers, but for also our health service providers. So our health service boards even have said, you're not in touch with us as much as you were because things had to change in the acute phase. Hopefully we can grab some of that back. So I think we had to do what we did. Now it's a chance to say, right, if this is the long haul, which it will be, how do we use the consumer engagement? It was such a theme of the Sustainable Health Review. We bring it into our business as usual from tomorrow.
Absolutely, and of course we can help with that because we've been building a community of interest in relation to COVID-19, and that community is building every single day. And they are a motivated bunch of consumer and community care reps, and they have been very generous in giving their time on a range of different things with very rapid turnaround feedback. So, here's one we prepared earlier. And also segues nicely to my next question, which was, what's going to be the opportunity for consumer reps to participate in development of policy and service responses? Because obviously we know things are going to be rolled back. What is that going to look like, and how are we going to be involved?
Can I just ask you, when you say things are going to be rolled back, what do you actually mean by that?
Well, what I mean by that is say, for example, one of the early things to change, and I've got a specific question around it, was elective surgery. So obviously it was off and then it was back on. So there's going to be a range of things we would expect where there would be a staged, perhaps rechanging, or, obviously all of us are talking about stuff we don't want to lose, like telehealth. Like, was it a 3-year plan for federal health to get telehealth? COVID, 6 weeks, away it goes. So, there's I guess it's in that sort of space that we're thinking, how can we be involved?
Well, I think I'll go back to what I'd said originally, is how do we get you involved from here in decision making? And I've got my colleague Nicole to my left, who you probably can't see, who's one of the Assistant Director Generals, who is passionate about consumer engagement, as well as the whole department is, but also I can say Nicole keeps us all honest about that. And so from here, I will actually ask not how we can get you involved in some of those things. What I would say is I'll go to telehealth. If you look at some of the numbers, in one area we did, I think, about one of the health services, about 165 telehealth consults, in January. By April, it was 5,000. We never want to go back. But what we want to interact with consumers about is saying what's worked, what hasn't worked, and how do we then embed the telehealth so it gives the best experience for both patient and clinician, ultimately to better patient outcomes. I think where Health Consumers Council can help us is that liaison with the Commonwealth, never to take also telehealth back in the primary healthcare space, because so it's both in the hospitals, it's also in the primary space as well. With elective surgery, I mean,
can I?
Yeah,
just while we're still on telehealth, I just wanted to link in there just to say here's one we prepared earlier, because we partnered with the health consumers across the nation. We did a online event with I think it was about 150 people, so across the nation, around telehealth was one of the topics, and it was really interesting. I think it's very clear that the consumer experience varies. And I also had the opportunity to have a conversation with a couple of clinicians, Fiona Woods, David Playford, and Rob Newton, about the same topic. And one of the things I thought was really, really clear is give consumers choice. Give them the choice. Is it phone? Is it video? Is it face-to-face? So that's the starting point. And I think also some of the telehealth have been much better than others. I mean, people are so excited about not having to go into the GP for a script. But some of the counselling appointments, for example, haven't been great experiences. So we have all that feedback we can just share with you, and there you are.
I think also we need to share it alongside with clinicians, because we want patients to be informed that if a clinician feels that it should be face-to-face, that patients and consumers are informed that it actually should be face-to-face and why it should be face-to-face, so they don't get put in a difficult situation.
I thought another interesting reflection, sorry to interrupt, but you know what I'm like, I always interrupt. But just that idea about, in conversation with clinicians was about the readiness of clinicians to adopt the technology very just as it did with consumers. So interesting reflection, I thought.
Well, I don't want to be anecdotal today, but as a clinician, or an ex-clinician, and when telehealth first came out and I was in Port Hedland and we were beginning to use it, we had the only machine, I think, in the Northwest. It kept going wrong, it was very clunky, and people naturally go away from it. If it's not user friendly, they don't use it. But we have seen such a transformation of telehealth, of remote monitoring, of remote assistance, that I think we're way past that now. And I think we've learned a lot out of this as well, what works and what doesn't work. We've worked as using Teams. So just to go back, just so I don't lose that on elective surgery, because it is so critical. We made a call, and it wasn't just we, it was nationally, for a number of things. One, we were expecting an upsurge of COVID cases, and we maybe not today talk about the modelling another time, but we were expecting an upsurge of COVID cases, and we always have to be ready for those cases. So we decided to take down a non-urgent elective surgery, and I recognise that has done that's not been good for patients, because patients have had to defer their surgery, but we've had a lot of understanding.
Yes.
We now, as you know, the Commonwealth went to a roundabout. They said you can actually go up to 25% of your activity. It was a soft target. I can tell you today that we are our health service is sitting at around about 55%. So they themselves have interacted, maybe well, maybe not so well, but with patients to say we want to bring surgery back. We want to bring surgery back for those people who've waited the longest. Yes. But also we don't want to misuse lists, elective surgery lists, so we want to fill those.
Yeah. That was a specific question as well.
Yeah, I think you'll find now, I've just seen a paper that we were working on last night with the Commonwealth, where we want to now ramp up elective surgery to, I'm going to be really candid with you, I want to get up to the 100% levels that we were before over the next 8 weeks. I have to also balance the PPE usage, our personal protective equipment, and I can talk a bit about that, but it's I have to balance that, and I have to balance being ready for COVID. So we will have to be very agile to say if we do get, and hopefully we won't, lots more COVID cases, we might need to pull down elective surgery, we need to do a bit of this. We have no community transmission at the moment. I can say that we've flattened the curve, but we have to remain vigilant and we have to expect little outbreaks that we will actually get on top of. But I want elective surgery back up to what it was before. I also want the privates to get up to what they actually were before, because we've got a backlog, and we were proud of our elective surgery performance. 96% of patients were operated on within boundary.
Yes, because that was actually one of the specific questions, you know, are there measures to support those who will now be facing even longer wait times as the system tries to catch up? And we actually did do a survey around elective surgery, and again, I can share that with you.
Yes.
But, you know, it's one of the conversations was around, you know, how, you know, is this going to make things worse? Can we use private hospitals more? That kind of conversation.
We can. Look, we've got capacity. Our hospitals are quiet at the moment because we expected an upsurge. We also, our emergency departments have been quieter. There's lots of reasons for that. That's not just WA, that's a whole sector. Our flu, so our non-COVID, our flu is the lowest we've ever seen. If you look at the graph of flu attendances at hospital, it looks like the graph is the wrong way. You need to turn it up the other way. It's literally now, there's lots of reasons for that: social distancing, everything we've done with COVID, and hygiene. Also, we had an atrocious flu season last year. We expect a better one this year. It'll be interesting to see now we're getting rid of some of the restrictions, what comes back. You know? Yes,
and that again, that was some of the questions were around, you know, I guess some concerns around when we relax restrictions, you know, are we going to see a surge? And of course the answer is, who knows? We hope not, but who knows? It's funny, I actually got the hand hygiene stats through yesterday. I thought they were all looking at the tracking in a good direction. And I thought, isn't that fascinating? Again, I think the hand hygiene nurses, long vilified hand hygiene nurses, are now kind of like seeing COVID's handed them a beautiful gift. And I think, but I think this is the key thing here is it's the community. I mean, we keep hearing that over and over again. It's the community and how we wash our hands and how we distance. It's going to help.
So I think all those public health messages
which are within our control.
That all remain the same. So personal hygiene, hand washing, social distancing, all those key messages, those public health will stay. We've got an outstanding Chief Health Officer, and I should acknowledge Andy Robertson and his team have done an extraordinary job and continue to do it. And we take this on the best public health advice, both at a national and at a local level. So in taking off some of those restrictions, the key messages here are you don't take off too many at once, because otherwise if you get an outbreak, you don't know which measure has potentially caused it. So that's why some of you are listening to me now will probably say you haven't gone far enough. Some of you might say we've gone too far. I think it's measured. We will now leave it for 3 or 4 weeks while we see what's happened. We've already had restrictions that were taken off on the 27th of April, and that was some elective surgery being put back. It was schools coming back, and also it was going from 2 to 10. Now that hasn't seen an upsurge in cases. Now we do the next thing. Obviously our interstate borders, our locked borders have been a real success.
Go nullable.
So I think you will see a measured response. And just because you see an outbreak, so I'll say this now, just because you would see an outbreak somewhere doesn't mean the restrictions go back on. We would, that really rapid contact tracing, that quarantining of international people coming in, home quarantining of domestic travellers who come back in, all those key public health initiatives will continue for the short term.
Yes, and presumably the COVID Safe app will.
COVID Safe app, hopefully everybody in this room, and everybody's got it on their phones. So
that sort of also segues to the next question for me, which is around number of visitors. So as we have changed the number of allowable people at an event, one of the things I personally would love to see, because this has had a huge impact on people, is number of visitors. I know there have been some beginning and end of life considerations. I'm not 100% sure if consumers have known they can apply for exemptions. You know, certainly my mother, who's in her early 90s, she had a friend very unwell in hospital, and said, look, you know, if they can ask for an exemption, it's end of life. But, you know, she was sort of crying and saying, well, they can't. There's only one family member allowed, and my dear old dad, you know, I must say, hospital's quite a good place at the moment. He was in that, you know, emergency, and he was straight through. Yeah. Anyway, but so he has to have the one visitor that was in the private system, but that one person has to come every time. What are we doing around that? 'Cause that's going to make a big difference to people.
We're actually looking at it, and obviously there are rules for visitors in hospitals, there are rules for visitors going to aged care facilities.
And aged care facilities, I have to say, have not covered themselves in glory.
No.
In this area, I don't believe.
Look, it does sound not particularly compassionate, but we actually, in this, and we've taken national advice. So again, this is not just local advice. This is done through a committee called AHPPC, which has all the chief health officers on it, and we do follow their guidance. You know, the aged are very vulnerable with COVID-19, and so whilst it might have felt draconian to do the visitor restrictions, we are protecting those patients who are most vulnerable. I think you will see a lifting at some point of restrictions, and I think it might be in our next phase potentially, but it will have to be taken on national advice. I think, and this is, I think, again, very candid, I think what you'll find is that potentially hospital visitor restrictions might alleviate before aged care ones, knowing that there are exemptions available. We haven't done it this time. People have criticised, I've seen criticism of some of the restrictions, even though we're ahead of the other states. Well, why haven't you let playgrounds go? Why haven't you looked at aged care facilities? For the very reason, if you took too many levers that are then unrestricted, then if you do get an outbreak, you do not know what's caused that. You've got too many to look at. So I take your point. What I can tell you is that Andy and his team of chief health officers around the nation are looking at the visitor guidelines.
That's good. And so there was just one more, just on that same topic, and that was from the parent perspective. So somebody wrote, as a parent of a man with an intellectual disability, I always stay with my son when he's in hospital or in an emergency. This is essential to enable communication with staff so that he feels comforted and safe, and to ensure he gets good care. Sadly, all of these have proven necessary over the years. And can the DG tell us what the situation is during COVID-19 for parents to stay with their son or daughter who may have the virus? And are there rules regarding this? So that's a bit more in that, you know, child, adult. It
is, and obviously there are guidelines within individual hospitals. Well, I did see this question, and probably what I'd like to do, rather than give you a anecdotal answer, is actually come back to you specifically on it. And what I'll then do is flick the response to Pip, who can flick it to the person who was asking. I think there's an issue here. If obviously it's your child. I've got 2 children. They may not want to be with me as teenagers, but I would like to be with them if they were sick. I think the thing is to be very conscious here, the fact that we want as much interaction from parents and families to the child, but we also have to, one, protect the adult. We actually have to protect other siblings in the family. That there are protections we can put in place in PPE. I think this would be a very specific case that we'd have to look on an individual basis. We also, I think, where we have been criticised is where maybe people who are whose life is ending because of COVID, where other family members have wanted to, and this is not just WA, this is actually around the world, wanted to be with them. There is a risk sometimes within the hospital about bringing those family members in who also have COVID. Now, we're not in that situation now in WA anymore. I just think hospitals, health services, we want them to be compassionate, to look at the guidelines, but look then on an individual basis what it actually means.
I like that. I was curious to know too, would there be potential to have some sort of easy access to the concept of asking for an exemption? Because I have had a few people saying, well, what's the process? And I thought, well, certainly, I don't know exactly what the process is. I know that from the Minister's office that's a process that's in place. We had some conversations around that around beginning and end of life. But I was just curious to know, how can we make that bit more
we probably don't. I mean, we could have an exemption process. That usually means, when it comes to the public service, more paperwork, and that can be actually increase the length of process. We hope that if you've got a patient in a hospital or a relative in a hospital doesn't meet the guidelines, if there are, hopefully the hospital can look at that at a compassionate level and make a decision. I'd rather that was done with some agility rather than more bureaucracy, but we will look at that.
Brilliant. I can see that I may have slightly gone off script, as I tend to, but I was just wanting to go back to that concept around so things have changed in terms of I think perhaps now we've got meetings at 10, but
Yep.
when do you think it'll be more likely that the consumer advisory councils and district health advisory councils en masse? I mean, obviously it's been different, they're not all the same, but some have still been meeting, some have not.
I think, look, honestly, we'll be back up to 20 on Monday. And I think, I've done it with my executive. I actually got a bit sick of them, not sick of them, but sick of seeing them. You didn't get sick of them, sorry, Nicole. I'm sick of them just seeing them on video, so I actually wanted to see them. And obviously work meetings were allowed. So what we did is got them together and got them into a room, a theatrette, and got good social distancing. I think the district health advisory committees, I think also, I think there has to come a time where if you meet the guidelines, and also there is a really important meeting where the majority want to get together and see each other and they're really good social distancing, then that's a good thing to do. And maybe those who have conditions, who are medically shouldn't do, they should do it by teams. But I think it's got to be, again, look at the numbers in the state. We're testing 60,000 people here. The numbers in the state, 0, 1, 1, they are the last case of where we really thought it was a community case was around about 35 days ago. So again, I don't want to not be vigilant, but sometimes it's so much better that we see each other in person.
And I'm going to do a slight counter to that, and I'll tell you one of the things that we have really enjoyed as an agency. Some of the things that we're going to be keeping on doing. We've really enjoyed being able to get people from Perth and the regions all together. So I had the experience again last week where I was on Microsoft Teams and everyone else was in the room. And it's like there's the shuffling of the papers and there's the conversations people are having that you're missing out on. What we love was the equity of everybody being two-dimensional. So there's definitely something we'll continue. We've actually got another one.
I would agree with you.
Running them quite regularly because people have been really engaged and interested and looking for somewhere to have, to continue to engage. Sometimes we talk about anything but COVID.
Yeah, it's nice to talk something
about
COVID.
Something else. Yeah. But I think there's definitely good in both.
I think we need the balance. I think we found it we meet monthly with my state counterparts, and I've certainly realised that we don't have to do that in person. We can certainly do that by what we've used in Teams adequately. Yes.
Not in love with Teams, but
Teams.
What we got. Yeah. So let me see. What's on the next thing? Oh, look, I have a specific question. That sort of gets back to that idea about services and what services are running and what services are not running. And again, it's not always clear when each other is which. But I did have a specific question around the oral health centre, and apparently that was closed. Have you got?
It was, yeah. Public dental work. Yeah, I do. Again, I'll come back to that exactly. Public dental work will come back. It is probably part of our elective surgery. It will incrementally increase. We've done a lot of work, obviously dental work. Initially, the Australian Dental Association, and this is in private practice as well for private dentists, were very worried because there is a higher risk. If you've got, and this is if we don't have this, so I want to preempt this, we don't have this. If you have let's say in America or the UK, where you have high degree of community transmission, when a dentist is obviously clearly operating in your oral cavity, there is a risk to the dentist, risk to other people as well. Now, there is very minimal risk here now because of no community transmission, but we still have very robust clinical guidelines that dentists can use. So we've worked with our clinicians in relation to what sort of PPE they need to use when they're doing certain procedures. So I would imagine dental work will start up, but slowly. Again, we have to do this very. Again, I don't know the answer to that when it opens, but public dental work can start over the next few weeks.
Thank you for that.
And I think I have a couple of mates who are some private dentists, and they, I think, are back to a lot of them are going back to work. We were going back to work as on Monday, but they take their advice from the Australian Dental Association. And the risk was very much for them was coming in from international travellers. So 85% of our cases in WA, over 553 or 4 cases that we've had, 85% were international travellers or contacts of international travellers, or cruise ships. And cruise ships, I know more about cruise ships now than I thought I'd ever want to know. But that's really telling. So the higher risk was in the beginning, the international travellers, before we put the quarantine in. And as you can see, we do, and you will expect, for everybody online today, you will expect us to pick up more patients who do come in and quarantined at hotels, because that's why they're quarantined. They're quarantined because they potentially have they potentially have COVID. There's not a lot of cases now coming in with it, but there will be the odd one.
Thank you. I have a really interesting question around public health messaging, because obviously we talked a bit about public health messaging and how important it is. But one of the points I thought was really interesting is how can we frame those positive messages? So this new normal of hand washing obviously is discussed, but also social distancing. And the idea was can it be less directive and don't do this and don't do that, and more positive? How could we have that more proactive approach to health promotion, a la sustainable health review?
Well, I think you could actually say what's actually happened with some of the other, the flu-like illnesses have gone down. The actual injuries, not probably the injuries have gone down, probably because there's not much sport being played. That's not particularly good, because then you get more unfit. But I think you can make it positive because they are basic messages. I think the other thing is to say, the thing I say and other public health advocates would say, it takes only one. So it takes only one case to cause an outbreak. It takes only a few outbreaks to cause a large upsurge of cases. So I think we need to be actually saying to people, if you don't do those public health things that we want you to do, you can get these cases which then can surge. And maybe we will talk about this today, about how the hospital system is ready. Because I do not want to give you the impression that we are not ready. We are very much ready. We have got, and maybe I'll just mention this now, we have, so to get ready, we, at the time where there was there were some shrill voices out there that were that were prophesying, if that's the right word, or being prophets of doom and gloom. I must say, in a certain meeting that Andy Robertson and I were named Doctors Doom and Gloom, but we were actually saying how we felt it could be.
Yes.
So we have to be ready. We have to be ready that. And people were seeing what was happening in Italy and in the US, all over the world. So what we did was, our main effect was PPE, and so we went and we got new suppliers. We've had, putting in the Minderoo to one side, we've had 2 plane loads we've secured from China. We've got new suppliers. Our supply chains have been severely disrupted. One of our suppliers just recently has cut their supplies to us by 30%. Because supply routes are shutting down. We are in a lot better situation than we were before, but we're not being complacent. So what my aim is to have 1 to 2 years of supplies for PPE sitting in warehouses. I unashamedly am doing that because I want to send the message, which is backed up by fact, that we are got staff and patients are safe. Because if staff are not safe, if we don't have enough PPE, then staff are not safe and patients are not safe. I can say now, on some of our PPE, we have over a year's supply. In others, we have about 8 to 12 weeks supply. That's a lot better than we were before. We're opening up new supply chains. So that's on PPE. We also did a surge plan for our ventilated beds. So we have around about between 120 and 150 ventilated beds in the system. So patients who can be on ventilators. We have a surge plan that takes us to 665 ventilated beds. Now that's across the system. How do you do that? That's a great question. How do you do that? Well, ventilated beds don't all have to be in intensive care. They can be in critical care beds. They can also be in theatres. They can be in other parts of the hospital that we potentially can make into ventilated bed capacity. We've also increased our number of ventilators from around about 300 to around about 720, and we have ventilators now coming in over the next 2 to 3 months. We've actually got more ventilators than we need at the moment. Yeah, that's not a bad thing. We bought 50 off Minderoo. We've got some of our normal suppliers have come in. We found ventilators, we found some very high spec ventilators in the most interesting of places. While Catcham is one of them, and Muck and Booden, I think, have got very high spec ventilators. I'm very pleased that they've got them, but we're obviously consolidating our ventilators across both the public and the private system. Again, can I say we've done this as one WA Health family. We are not looking at this as public and private. We have an agreement with the private hospitals where we retain their capacity because we may want to use it. So there is a, so I can say our critical care bed, it's not just intensive care, our critical care bed capacity, we've got a plan in place. We've got plenty of ventilators at the moment. We've got more coming in. We've also gone out to workforce. We have a pool now of about 5,000. We had 5,000. Well, actually, I think we had about 15,000 hits on our workforce pool. So we want people to come in and say, yes, we want to work for you. We now have pools of people. We also, with this lull over the last few weeks, we've been able to train our staff in critical care training. So it's not across the board. I do not want to paint a picture we have got this completely sorted, because that is not right. But we have done a lot of training of our staff in critical care. So when this comes, and if it comes, because hopefully it doesn't, hopefully we might get a vaccine, but we are ready. And that has been our mantra in the health department, to say we want to be ready for staff and patients.
Thank you. That's very interesting. I must admit, I have been wondering what is happening in the COVID clinics.
Yeah, they're still pretty busy.
That's
testing in the COVID clinics.
Yeah.
Yes, so we do have our COVID clinics. We have private, so you can go to your GP, or you can telehealth your GP. You can telehealth your GP, and they can give you a form. You can go to one of the private pathology providers, and obviously in the regional areas, you can actually be seen at the hospital or at specific clinics. There's one at Bunbury. I think there's some walking clinics in the southwest. So we're around about 1,400 tests a day. That doesn't take into account the industry tests.
As in like, say, like fly in, fly out work.
Yeah, fly in, fly out, we'll add to that.
Yeah.
There's a little bit of noise around testing in WA. Volumes wise, we are lower than some of the other states, but we are now doing more tests per 100,000 population than South Australia. In the last week or 2 weeks, not volume wise, we're doing more than South Australia, Queensland, Northern Territory, and ACT. In the testing, we have a very low threshold for testing. So the figures today, the ones who went to the COVID clinic, around about 750 patients went to COVID clinics across the state yesterday, and we would swabbed about 680. Now, you say, well, where were the 70 who weren't swabbed? Well, they usually come from patients who come and say, I just want to test. You've got to either have a temperature, either have had a temperature or have a respiratory system. But what I would say to all of you is you are encouraged to go and get a test if you're symptomatic. We want you to have a test if you're symptomatic. We don't want you to rock up at the COVID clinic if you've got a sprained ankle and want to test. That has happened on occasion. But we are swabbing most people who come to clinics. There's a lot of debate about swabs, i.e. things in your throat, and also blood tests. If I can say, we through the Chief Health Officer, we recommend we are only really allowing swabs. Blood tests have a role, but they are not accurate enough. So the swabs are so I don't know if you want me to talk about that. There's a lot of debate out there at the moment about swabs, and you hear about blood tests. Blood tests are useful for research. They're useful to tell if you have had COVID.
And so that would be things like, perhaps, you know, that you've had it and you've got immunity.
Well, Pip's an important point. So I've read more about that. Well, we've all read more about this. Pip's right. If you have a blood test, it will show if you have an antibody to it. We are not yet sure if it gives you immunity, and that's not, Australia is not yet sure, the world is not yet sure. And that's because we've only had this disease since late December. What we can tell is, yes, you've had the disease, you're not infectious anymore if you've had the blood test, but it doesn't say for sure that you won't get it again. So the most important test that you can get is what we call a PCR, and the PCR is the swab test. It's the one we do right around the country. It's the one, if you rock up at a COVID clinic, it's not particularly pleasant, you will have a test. What we are also doing is research. You would have heard that in the schools we are doing some cohort studies for for school kids and teachers, and the education department are picking, I think, 40 testing schools and 40 what we call control schools that don't get tested. This will roll out in the next couple of weeks. It will be purely done by consent. We're not going to be swabbing children who don't want to be swabbed, but it will give us a hopefully the community and the broader system an ability to see if there's any disease. One, in school kids, we don't think there is, but also we're going to go then to healthcare workers, police as well, but it'll be part of a research trial. You would have seen in Victoria, they're the only state to have done this massive 100,000 asymptomatic testing. The chief health officers don't support that. Out of that 100,000 testing, only 30 new cases were actually found. And the issue that I have is we do have lots of tests now, but we also have to be really responsible in making sure those tests we have enough if we get an upsurge. The worst thing we could do is run out of those. So it's a balance. But hopefully that gives you a bit of information about the testing. There's a lot of debate about testing. Lots of people who tweet on Twitter about testing, but we rely on the Chief Health Officer's advice.
Well, yes, that's a very long response. So thank you so much. That's interesting. And so just to recap, you do have to have some kind of symptom
or a history of a symptom, but it's a very
sort of contact.
It's a very low threshold.
It's a much lower threshold than one.
Oh, absolutely, and everywhere is like that around the country. Also, your ability to get tested. Is and also what I would say, if you were tested once and you felt unwell, that's fine. If you feel unwell again, it doesn't mean just because you've been tested and you're negative, you can't go for another test. You can go for another test, and you should go for another test.
I was interested too when you were explaining around the PPE, because everybody knows what PPE is.
Of course they
do. Before they do now.
Yeah.
But I certainly remember the Mark McGowan with the great warehouse and
yes,
pictures
of one of our
Facebook,
planes. That's right. Yeah.
That was one of your planes, right? I think what people are interested in too is we're interested in. It's great to hear that public and private hospitals are sharing across it. Obviously, we're interested in a care place. We're interested in people providing care in the home for age and disability. There's quite a theme through the questions around the importance of vulnerable people in particular. One of the questions actually talked about, it says, what rules does WA Health follow to ensure people with disability are treated equitably during COVID-19? Well, I guess a lot of us saw, say with Italy, for example, it sort of kept getting, that was an ageist thing, kept getting younger and younger and younger, that you would not be offered a ventilator because you're actually at the ration, that awful rationing care thing, which I know we are a long, long way away from. But, there has been some interesting conversations. Again, the health consumers across the nation have, did a forum on that, and we can share some insights from that. But I think, there has been some really interesting community conversations around this, because, whilst this is something I think clinicians have been doing forever, it's something that really came into public consciousness only really in the last 3 or 4 weeks. So,
I would say we need to treat people in the same compassionate way, and with exactly the same way as we always do, always improving, whether we're in COVID or not. I think, you saw those horrific signs, what was going on in Italy. What we do with anybody coming into intensive care, and this is nothing to do with COVID, but anybody coming to intensive care for either an elective or an emergency condition, the doctor should talk to the patient, the team should talk to the patient, the team should talk to the family, and be really open and honest about what intensive care means. We know through COVID, going back to COVID, that some patients and their families have actually said, I'm choosing not to go, I do not want to go on a ventilator. Now we know that. And we should be really, we should actually be really respectful of that, and that's no different, as Pip just really well put. Doctors have been doing this for years, so what we want to take an ethical, compassionate approach to this, as we should do at any time. And people should know if a patient is, and we've had quite a few patients on ventilators in WA, and ventilators, and many of those actually came from the cruise ships who got sick here, and we were very compassionate to those people. We didn't want another Ruby Princess, but there were people who were very ill. There were people who chose to say, I want all the treatment, but I don't want to be on ventilators. Now that is up to them, and they should do that in consort, in liaison with the clinicians who are treating them. This is about informed consent. This is about informed knowledge between clinicians and between patients. So we're not in that, you use the rationing word. We're not in the rationing word. No. We're nowhere near that, but it's about knowledge. It's about knowledge. People should be informed. We're now getting, there's a lot of, in the medical literature, there is a lot of information now coming out about how patients recover who've been on ventilators, and those who recover and those who don't. And we'll learn from this. We'll learn very well. I mean, obviously, we haven't talked about vaccination, but obviously that's what everybody is sort of looking at.
No, because I was just thinking that I was going to say at the end, the vaccination one is quite a big one, and they actually thought would be a juicy topic for another whole section.
And maybe with an expert at it.
I think an expert would be awesome too. But I just thought, I think one of the reflections I would like to make too is we're having a consumer catch-up tomorrow, and the focus of that is, obviously, acknowledging Palliative Care Week. We do think the community is really much readier for a lot of the end-of-life discussions than perhaps it has been in the past. And I think that is that, that's that meeting in the middle, that shared decision-making. I think there has been some concerns around, people with disabilities. Sometimes they may have encountered some ableism in the health system. It's just, it's a thing.
But I think that probably was a thing before COVID. And I think, if that's there, we want to learn and improve. I would say, on the work we're doing on end-of-life care, and that is, I'm not talking about COVID now at all, I'm moving on to end-of-life care with our palliative care strategy, with our voluntary assisted dying legislation, which was passed by the state government at the end of last year, and also in our advanced healthcare directives. That whole work, we have a team in the department who are working on that completely irrespective of COVID. They're working on that. The work is expected to be completed over the next 12 to 18 months. That should, and we're also trying to get a bit of normality back, where there's been some of the things in relation to sustainable health review. Some of the things we would do as business as usual has had to take a backward step. We're trying to get that all back on track.
Absolutely. And I would just say, as co-lead of recommendation for new ways of engaging with consumers, next week we'll be back on it. Ryan, if you're listening, just get ready. I do think that I was hoping that I could bring us into the end on a slightly more positive note, because we are, as you say, we are very lucky where we are, and I think apart from New Zealand, because we all love to see you are doing, but apart from New Zealand, we'd like to live here because it's so very good in terms of how we've done quite well. But one of the questions we had was, how are we going to take some of the positives that have come out of COVID-19? We've talked a little bit about telehealth, smashing through, getting that done. I know there will be other things. I know for ourselves as an organisation, online engagement is something we use to a greater degree than we have in the past. I'm sure there are many other things, but how are you going to take these positives into consideration as you move forward?
Look, I think that the work.
I suppose I could say is, how can we help?
And I think we're going to capture Nicole, and maybe this is another discussion of a fireside chat with Nicole, but we're doing some work on sustainable health review. We've got a blueprint for the future. That's our SHR. We've got innovation happening under each recommendation. We should capture those, enhance them, and we're going to be really honest about the ones probably where we think we won't make the inroads that we thought we would do. But there are some, not just telehealth, there's some on public health, on the public health engagement, on the public health spend, on the focus. Why are we not now? We're talking about a public health emergency. We should be using that. That was recommendation 1 on public health. So
it was the kind of,
apart
from the engagement with consumers, of course.
It was the spend, the focus. We shouldn't lose that. So we will. And I think that is probably a discussion with Nicole on a fireside chat in relation to and working with the community and saying, well, this is our take on the sustainable health review recommendations that should be at the forefront. Is it yours? And what have we missed? So, I think we can be positive. I actually think we can finish on a positive note, because We are in the comfortable position, only comfortable, that we have had time to prepare. I think a lot will be more, what I would say is I'd probably like to do this again with Pip maybe in 6 to 8 weeks time, because in 2 months time we will actually we will reduce some of our levers. We'll know how that's worked and what we can actually do as a state. Can we really, when I say open up, can we really get back to normal and also continue the innovations and what we've learned from COVID? And by then you'll have had a chat with probably some vaccination experts, because if vaccinations don't come, we need to be, and the narrative very much is living with COVID. It's living with what is the threat out there, but living with it and adapting our lives towards it.
Absolutely. So I feel like we've had a really great chance to really deep dive into quite a few of these things, and I really do appreciate, as I say, you're an extremely busy man, so I really appreciate that you've given us this time. So people who are watching us, you will realise, I'm sure, that we have not, in fact, that's Russell with his papers.
Yeah, sorry, just looking if we have, we've got to 5 more minutes, so are there any other questions you want to cover?
Well, I feel like we've really reached that point where there's some really big ones that I think we want to talk about in the session. So one of them was vaccines, as I say. So we have actually already received some questions around vaccines, but we will plan another session. So as mentioned, we're planning to run these fortnightly on Thursday, and we just need to double check who we'll have next time before we pick a topic, but we'll obviously keep you posted on that.
I might just say something about what government's doing on recovery, just to give you a picture of recovery. And I'm very much, I'm going to talk how we're talking, which is the middle game and the long game. So whether it's AFL or cricket, whatever is the love, it's the middle game and the long game. And because this is we're in for the long haul, in my view, the middle game, we talk about recovery, but the middle game is response and recovery. It's that balance, recovering, but being able to respond. It's great public health response. It's having an acute system, a hospital system that's ready. It's having that balance. The long-term recovery is either with a vaccine or with herd immunity, and I do not concur to the herd immunity argument that was being pushed in the UK. I'll just say one thing about herd immunity as a clinician. Herd immunity is where you have enough of the community who either had the disease and are immunised against it, and that's a question I've covered on, that you not necessarily get immunity. For this disease, you would need around about 60% of the community infected and have had the disease. That's not even happening in Italy or the UK, where they're getting maybe 15 or 20%. So that is not something that the AHPPC, the CHOs are going down. So we're clearly looking at vaccination. So when we look at recovery, we look at the middle game and the long-term game. The long-term is that, either it's treatment, because there are now treatments out there for viruses and some very positive stuff coming out on treatments. So treatment or vaccine. And so in recovery, we look at it from health, social and economic. So health is very much, and you've seen some of the levers that have come off that are low risk, and then we go to medium risk and then higher risk or higher risk. And then we look at the social impact, because there is a real, and probably we haven't talked about this, the real social impact on mental health, on the lack of community engagement. I'm not talking about consumer engagement, community engagement, yeah. But that social and also economic impact. So when governments look at releasing levers around the country, they look at health, social and economic. And that's when you look at some of you say, well, why did government didn't open playgrounds in phase 2, but they did open cafes for 20. Again, you could open everything, and then if something goes wrong, you have to shut everything, or you don't know where you're looking. So there has to be an argument, but a balance between health, social, and economic. So I think I just wanted to make sure that when we talk about response and recovery, we're looking at in those 3 prisons.
Got it. So I would just like to remind our registrants that we are really interested in your feedback about this event, as noted event, and we do hope that the technology has been okay your end. That is one of the questions in the survey that we're sending to you, which you'll get about half an hour from now. It'll land in your inbox, so we'll be really interested to see.
I just hope the technology has worked, otherwise Pip and I have been talking at a laptop only when we could have been talking together, so let's just hope it's worked.
Fireside, but yes. And so obviously we'll be looking to get, my understanding is a video which has been, edited a little bit. I think there may also be an audio, and there will certainly be a written report from the event. So keep an eye on the Health Consumers Council's COVID-19 page. I believe there will also be one in the Health Department. We'll make sure that there's a clear link to that as well. If you are not already in our COVID community of interest and would like to join, please do feel free. So I think really that's. I'd just really like to finish just by saying thank you to everyone who's come.
Yeah, thank you.
I'd really like to say thank you for your time, and thank you to the whole team. You can't see them, but they're all sitting down in the table, who've worked so hard to make this happen. And we look forward to seeing you in a couple of weeks.
Thank you very much, and hope you've all found it useful. We would love to get some feedback from you and any specific questions. And there may be questions, can I say, that are sensitive or specific. I think we've had a couple here. We would come back to you on an individual basis. Thanks.
Thank you so much.